تعالي نل.
Hello, hello. Greetings, everybody.
Hello?
How are you doing, Martin?
Yeah, I'm fine. I'm pleased to have Atul Goel with us. He's really a very entertaining and very knowledgeable neurosurgeon, isn't he?
Oh, that's why he's the king,
He's the king of the kings in the East. Yes.
the king of Zoom,
Yeah.
because he did a lot of these during COVID.
Yeah, he did. I know.
He's still doing a lot. But when he travels around the world, he meets people that see him online that didn't know him.
Right.
He was surprised because he went to Brazil, he went to Colombia, and he was pleasantly surprised that a lot of people came up to him and says, "Hey, Atul, I watch you on the internet."
Right.
So this is not totally wasted time.
So
You're there, Abby, right? There she is. How you doing?
Hi, John.
She's the brains
Dr.
behind
Martin.
this operation. You can blame
Yeah.
her.
Don't blame me.
Okay.
Abby, how are you doing?
I'm good, Dr. Martin. How are you?
Yeah, I'm fine. I gave a lecture, but apparently the pictures were fuzzy or something. I have an old computer here still running Windows 7. I don't know. Maybe I should upgrade.
Yeah, you should.
he had trouble with the PowerPoint. Is that because of the program, Martin? Is that because of
No, it's an old PowerPoint as well. The whole
Okay.
thing is, but to set it up, it's not about buying a new computer. It's about setting up everything, so that's always a big job, isn't it? Yeah.
Good day, Mr. Select, Dr. Select?
Yes, Mr. John, how are you?
Good, how are you? Good to have you here.
Fine, thank you very much. Hi, Abhi.
Hi, Dr. Salik. How are you?
Yeah, I'm fine. Nice to see you all here.
Yeah.
Hi, when is King joining?
Well, the king wants his trumpets ready. The trumpets have to be up. Right, Abby?
Yeah.
It needs to be up. And the
He's
violin
joining
too.
Abida knows when the king is coming.
He'll come soon.
Well, should we surprise the king with a standing ovation? The thing is, nobody has the camera on. You won't know whether it's standing or not.
Yeah, there is no camera in this.
Yeah, not many people have their camera on. He's doing this on purpose to, to build a suspense. Yeah, while we're waiting, I'll show you guys the webcast we have after this. For those of you that speak French. Oh, here he is. Okay. Hello, Dr. Goel.
Hi, John.
How you doing?
Very good, my dear John.
Well, you know, Atul, I asked the audience to bow when you came in, but you can't see them because they have cameras are not on. Imagine them bowing now.
Yeah.
Okay, ready to roll?
Yeah, everything okay, John. Let's do it.
Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2. Good afternoon from Miami Beach. This is Dr. John Bennett broadcasting from Miami Beach for the Neurosurgical TV channel. Today we have number 3 in a series of Dr. Goel's series. I'm sorry, I'm having a blank in the name of the series. But anyways, he's on number 3, and I'll let Atul explain it. Welcome, Atul.
Thank you, John. And Harshad is there. John, you want him to introduce the show?
Okay, who?
Hello.
Who should I introduce? Okay, well, maybe I'll introduce Harshad.
Hello.
Harshad, do you want to introduce the king?
Yes, it's
Go
my
ahead.
privilege to introduce Professor Atul Goel, who doesn't require any further introduction. If you don't know him, you don't know the neurosurgery. So he is the master of webinars, all lectures, and I don't think there is anyone in this under this earth has got so much experience on C1, C2 like him. It's our privilege that every time he's giving us a new insight of C1, C2 management. We are all eagerly waiting for Professor Goel to enlighten us by his vast experience of C1, C2. Professor, it's yours. Floor is
Okay.
yours.
Thank
Looking
you,
forward.
Harshad. Thank you. And I'm very happy and very proud and very honored. And thank you, John, for organizing all this. And I'm going to, as Harshad has said, I'm going to present on my very favorite subject of atlantoaxial instability. As I move further in this business of atlantoaxial instability, I realize that atlantoaxial instability is tremendously common clinical entity. If I have to say that in the entire field of spine surgery, atlantoaxial instability is the commonest. Atlantoaxial instability is the most neglected, most misunderstood, and most undertreated clinical entity in the subject of spine. It is not easy, it is difficult to treat atlantoaxial instability, but if you treat it properly, you give new life to the person. And that is what the subject of spine and subject of neurosurgery is all about, to take the risk and produce the results. So atlantoaxial instability is quite common, and I want to discuss this in 3 parts. It is such a huge and broad subject that I cannot talk about the entire field of spine, atlantoaxial instability in 1 part. So this is part number 1. Craniovertebral junction was hardly understood in the year 1964. And if you can read this, the first line of this article, craniovertebral anomalies have only recently emerged from the realm of anatomical curiosities into the more practical world of clinical neurology. So it was basically diagnosis and just wait and watch and do nothing about 60, 70 years ago. And if you read the entire article, you will find many of these patients did have craniovertebral junction anomalies and atlantoaxial instability, and they could have been given absolutely new lives, which was not done at that point of time. So this is my very favorite slide, as you have seen, many of you have seen several times. Craniovertebral junction is the upper V of the Y, upper V of the Y. It is like this kind of pillar which bifurcates and hold the roof. So there is a bifurcation. So this bifurcation gives power and strength to the pillar. And it is in most of the well-known pillars of the world, you will find such bifurcation at the top of the pillar, like here. So this V of the Y is the craniovertebral junction. And this V contains two very important joints. One is occipito-atlantal joint, and second is atlantoaxial joint. This is the majestic atlantoaxial bone, as I have discussed several times. If you see the upper surface of the facet of atlas, there are many strong points of attachment for ligaments. And on the lower surface or the axial surface, there it is round and smooth and flat. This is a little bit of a cup shaped. So in my calculation, craniovertebral junction instability means atlantoaxial instability. Craniovertebral junction stabilization means atlantoaxial stabilization. Atlantoaxial instability, because of the round and flat kind of structure of the joint, the instability can be circumferential. Instability can be, atlantoaxial instability can be when the facet of atlas goes in front, can go lateral, can go posterior, can go medial. So there can be a circumferential instability. And we know that the facets of atlas and facets of axis are firm and strong and very strong, and they form the basis of my technique, which we described in 1987. And now we all know that this technique, and in my estimation and in my experience, this is an absolutely fantastic, strong technique of fixation. And I have discussed this at least 500 times, that my technique since 1987 involves opening of the joint, removal of the cartilage, and putting bone chips inside the joint and then doing fixation. Craniovertebral junction instability means atlantoaxial instability. Craniovertebral junction stabilization means atlantoaxial stabilization. We describe these screws in the occipital bone for the first time in the literature, as you can see here. But now, for several years, I have excluded the inclusion of the occipital bone in the fixation construct. It is not necessary. It is suboptimal. It is weak construct, and you can have problems. Of course, if you are not able to do atlantoaxial fixation, you can include the occipital bone, but you have to realize that suboptimality in this field of atlantoaxial or craniovertebral junction is not a good thing. If you have to do craniovertebral junction, you have to do it 100%. You cannot have suboptimal situations. So this kind of occipito-cervical screws and fixation, which I used to do on several occasions, is completely. And if you read the literature and if you see the various articles being published from all over the world, occipital fixation is still very common and very commonly and frequently done by various neurosurgeons and spine surgeons all over the world. I have completely abandoned it. Most important thing when we try to understand atlantoaxial instability, we have to understand very clearly, and I will invite you to read this editorial of mine, where we discuss what are the indicators of atlantoaxial instability. Atlantoaxial instability can be diagnosed by various means, and I will be discussing as to how to diagnose atlantoaxial instability. About 35 years ago, there were only two types of atlantoaxial instability. One was mobile and partially reducible, mobile and completely reducible, and irreducible. So there were two types were diagnosed universally. This was the understanding in the world of craniovertebral junction. There are two types of atlantoaxial instability. If it is completely reducible like this situation, the treatment was fixation. If it was incompletely reducible or partially reducible or completely irreducible, the treatment was decompression from front or from behind. And in the 1980s and 1990s, the transoral surgery and transoral decompression was extremely popular, and it had gained a lot of ground in those 2 decades. But now, of course, as you know, that decompression is absolutely a negative form of treatment in the craniovertebral junction scenario. So one instability, one atlantoaxial instability was mobile and completely reducible. The treatment was fixation. So we had several cases of over the years in children, in adults, this was an infant, few months old, and you see mobile, reducible, having some kind of cord changes, partially syringomyelia, and the treatment was atlantoaxial fixation. So since 1988, we have adopted this kind of fixation. And earlier, we all know that midline fixation procedures were being done, wiring, hooks and clamps and loops and various kinds of things were done from the midline. Then Megal's technique in 1981 or 1982, transarticular fixation was becoming popular. And then we introduced this technique of ours. Of course, mobile dislocation, reduce and fixation. Dislocation, reduction, fixation. So over the years, we have treated several hundred patients of mobile. This was fracture odontoid process and fixation. So if you are able to do fixation, if you are able to open the joint, if you are able to do a solid fixation, put bone graft behind, put bone graft in the articulation, you can give a completely new life to these patients. And here are some examples. Here, fixation. In the year 2004-2005, we introduced the concept that irreducible or fixed dislocation, atlantoaxial instability, is not fixed. It is mobile. It is pathologically mobile. There are abnormal movements, and it can be reduced. So reduction of fixed atlantoaxial instability, this concept we introduced in the year 2000. And there is no hesitation for me to say that these entities which were considered to be fixed and where the treatment was decompression, this article completely revolutionized the field of craniovertebral junction, and then people started talking of reduction techniques. So this is inflection, extension. This is completely immobile and irreducible, but you can open the joint, manipulate the facets, and reduce. So this is, even if radiologically it is a fixed dislocation, you can mobilize the joint and you can reduce the dislocation and you can stabilize, and instantly you give a completely new life to the person. Other wonderful thing I want to tell you, and very clearly I want to tell you, that compression, as this compression that you are seeing, is of course due to the unstable situation, but more than compression, It is instability which produces symptoms. If suppose the person is fixed solidly in this position, there will be no symptoms or no progression of symptoms. However, if it is unstable and if it is mobile and it is pathologically mobile, there will be symptoms. So irreducible, the whole world was doing transoral decompression, open the joint, distract the facets, reduce or manipulate the joints, and odontoid process can come into normal situation. And more importantly, you have given instantly a new life to these patients. So we have got several patients in flexion extension, no movement. And now here, if you see the reduction is incomplete, although it is quite significant, but it is incomplete. Incomplete means nothing. Stabilization is the thing. Firm stabilization. Instability is the issue in these cases, and stabilization of the atlantoaxial joint is the treatment. Initially, when we described this reduction techniques, we were introducing intra-articular spacers, but now we have almost reduced quite remarkably the use of these spacers. So this is another case of very, you see, fixed dislocation. So-called fixed or irreducible dislocation. In flexion, in extension, there is no change. So do not do any decompression. Open the joint, distract, manipulate, reduce the irreducible dislocation. This was another case where the child was holding his hand on the chin to hold the neck. Both the facets of the atlas are dislocated and fixed in this position. So open the joint, manipulate the facets, and reduce the dislocation. This is another very beautiful entity that we described several years ago called vertical atlantoaxial instability. It is like a piston. You see, there is on extension, it comes down. On flexion, the odontoid process goes up. So it is like a piston. And this neck is short neck. No question, even if there is no real compression here, there is compression here, but instability is the issue. And I have to tell you that vertical atlantoaxial instability is quite a common clinical situation in atlantoaxial dislocation. Vertical, mobile, and reducible. So this entity was never discussed before in the literature, and we described in the year 2009. And we, for this kind of situation, this vertical instability, we introduce intra-articular spacers. And as I have mentioned to you, I used to use intra-articular spacers quite regularly, but now I use bone graft into the articulation much more than spacers. Another entity that we described on the basis of facetal alignment was lateral atlantoaxial dislocation. Lateral atlantoaxial facetal dislocation. So you see the facet of C1 is laterally dislocated over facet of C2. And there is tuberculosis of the contralateral facet. There is breakage of the arch of atlas, and the facet has displaced downwards. So what we have done is open the joint, did fixation on one side using spacers and plate and screw, and the person is cured. Lateral dislocation. When bifid anterior and posterior arches, when there is a bifid anterior and posterior arch, it is a dynamic process, and you do flexion, the facets go laterally. There is a lateral dislocation of the facet. There is vertical reduction of the height of the craniovertebral junction, if you realize, and the facets are displaced laterally. So this is lateral atlantoaxial instability. So there is bifid arch of atlas, and there is a lateral facetal instability. See, the facet of atlas is displaced laterally and downwards. So if you see bifid C1 arch, it is atlantoaxial instability. You don't have to see any compression or anything. Bifid means atlantoaxial instability. Bifid means a protective, natural, adaptive phenomena. Bifid means atlantoaxial instability, and the treatment is atlantoaxial stabilization. Any kind of decompression will be certainly an absolutely negative form of treatment. And over the years, we have treated several cases of bifid. And if you see here, we have discussed a few years ago our experience with 70 cases. Now we must be having several more. Bifid arch of atlas, when it is there, midline operations are not possible. Midline wiring is not possible. And that is one indication of facetal fixation, one of the several indications. Now, even if the child is few months old, the arch of atlas may be cartilaginous or may not be well formed, but the facets are very well formed even in an infant, and you can do C1, C2 facetal fixation. Lateral dislocation can also happen following trauma. So there is a fracture of the arch of atlas, there is complete fracture, and you see a facet of atlas is dislocated laterally. Now, one beautiful thing I have to tell you is, even if you see the facet of atlas is dislocated laterally over the C2, it is dislocated laterally over the C1 also. But the treatment in this situation is C1, C2 fixation, and nothing has to be done for the occipital bone or the condyle. So the treatment of lateral atlantoaxial dislocation in a case of facetal arch of atlas fracture is C1, C2 fixation. Occipital fixation is not necessary. You can have a complete disruption of the ligaments and the C1 can go beyond the C2. There is this facet you see is completely not touching the facet of C1, is not in continuity with the facet of C2. You open the joint, manipulate the facet, and realign the craniovertebral junction. So this art, this technique, and this method of opening the joint and manually manipulating the facets is an absolute revolution in the field of craniovertebral junction. And as I have mentioned, that craniovertebral junction instability or atlantoaxial instability is quite common, not very well understood, and a frequently encountered clinical entity all over the world. So we have to learn these fixation techniques properly because they can give new life to the patient. Rotatory atlantoaxial instability. I will discuss in my part 2 of my presentation that rotatory atlantoaxial instability can create a havoc in a person's life. Like this child, there is facet is rotated on one side. And if you do not touch this, this patient may not have any pain or any kind of other symptom. If you do not touch this or do not treat it properly, over the years, the entire dorsal kyphoscoliosis can happen and the dislocation can become huge and the deformity can become remarkable. So it is very important that you treat this and the person has to look straight. So learning the art of opening the joint, manipulating the facet and bringing the articulation in alignment, it can give not only new life instantly, but a long and wonderful neck. And this is not such an uncommon situation. So this is called atlantoaxial facetal locking. And this kind of manipulation of facets and realigning the neck was first described in this paper. Before that, there was no treatment for rotatory atlantoaxial dislocation. People used to give traction and halo fixation, and some people used to do decompression if there were neurological symptoms. But this art of manipulation of facet has completely revolutionized the treatment of rotatory dislocation and given new life to these young and old people. The other thing which I have talked repeatedly in my various lectures on the subject is that basilar invagination was considered to be a fixed anomaly. Group 1, where odontoid process is going up, group 2, where Kia tonsil is herniating down. So this was considered fixed anomaly about 25 years ago. And the whole world, there was only one treatment, and that treatment was transoral decompression for this and foramen magnum decompression for this. The entity was fixed and the treatment was decompression. So for the first time in the literature in 2004, we said that group A is unstable, group A needs realignment, and this realignment can be done by opening the joint, distraction of the facet, and bringing the odontoid process down. There is no question of doing any kind of decompression. In 2004, my impression was that this group needs foramen magnum decompression. So over the years, we have treated several hundred patients of group A basilar invagination by opening the joint and realigning the craniovertebral junction. Basically, the concept is instability is the issue. These are not fixed, and there is no question of doing transoral decompression. The other thing that is not necessary is to include the occipital bone in the fixation construct. This problem is C1, C2 instability, and the solution is C1, C2 stabilization. So this is basilar invagination, open the joint, assimilation of atlas, do C1, C2 fixation, and realign the craniovertebral junction. Basilar invagination, realign the craniovertebral junction, partial assimilation, partial bifid C1, and beautiful realignment. The other thing which I want to warn you, that it is good to have realignment, but it is not mandatory to have realignment. It is an unstable situation, and good solid stabilization is the treatment. Realignment is good, but realignment is not the aim of operation. Aim of operation is stabilization, and a very solid stabilization. This is another case of basilar invagination. You see, it was considered to be a fixed anomaly, inflection and extension. There is no change. There is, facets are quite malaligned. Open the joint. Learn the art of exposing the C1 facet. Put bone graft into the articulation. Distract and realign. And you have instantly given a new life to these patients. No matter how the facets are under traction, you can realign, you can reposition the facet, you can distract the facet, you can do a solid fixation. You see how the facet alignment is there and how the realignment is there and how the whole story has completely realigned. More importantly, you have given a new life to these people. This is, you see, there is hardly any space here in the foramen magnum. No need for decompression. You open the joint, do C1, C2 fixation, and realign the craniovertebral junction. So flexion, extension, no change, compression, facets, realign, do C1, C2 fixation. As I have mentioned, now over the years, we have got several hundred of these kind of cases where there has been no decompression, and decompression is completely out of my surgical armamentarium, a procedure that I had loved and that I had used on several occasions, and realignment is the answer. So this is basilar invagination. You see how you can realign, facetal realignment and surgical stabilization. This was my first case in the year 2004, where I had done realignment without transoral decompression, and this patient had come on a wheelchair. The father was holding with two hands. After 2 months of surgery, he is walking, father holding with one hand, and there is stabilization and bone fusion. This is another case of basilar invagination group A. severe basilar invagination, fixed arterial anomaly is there, whether there is arterial anomaly or no arterial anomaly, whether it is high riding vertebral or no high riding vertebral. Open the joint, remove the articular cartilage and realign. So this is a fixed atlantoaxial instability which was considered to be fixed. And as I have mentioned, about 30 years ago, there was only two types of dislocation. And if you read Dr. Menezes' articles, he has mentioned on several occasions that fixed and mobile. And this is another case. And initially, as I mentioned, I used to do intra-articular spacers, but I don't use these spacers anymore. Severe basilar invagination reduced. So there was an era of decompression. Then there came an era of decompression and fixation. And now the era is of craniovertebral realignment and only stabilization. Transoral surgery is certainly, and without any doubt, still you will be surprised that many people in the world and everywhere in the world, even in any country that you know, transoral surgery is still done quite frequently. Compression is still considered to be a very important issue, and decompression is still considered to be a critical treatment form. So the facets are the issue. All the muscles of the spine are focused on the facets, and the instability is first manifested at the facets. This concept was not there in the literature, because facets could not be seen on plain radiography. The only thing that could be seen was the odontoid process, and the whole subject of craniovertebral junction was focused on how the odontoid process moved on flexion and extension. So facetal instability, facetal malalignment, these are the initial affection of when there is instability that is due to either injury to the muscles or weakness of the muscle. If you read the literature, the whole literature is talking about craniovertebral junction anomalies. I am saying they are not anomalies, they are not congenital problems, they are not embryological dysgenesis. They are due to injury to the muscles somewhere down the line in fetal life or in early neonatal life, and that leads to weakness of the muscles and facetal malalignment. So I don't like to call them craniovertebral junction anomalies. I like to call them craniovertebral junction alterations. Now you see this gymnast, there is quite a severe movement of the neck and quite a severe movement of the hip. So this is the mind part and this is the hind part. So there are several similarities in the mind part of the spine and hind part of the spine. Like lumbosacral listhesis, there is C1, C2 listhesis. And I have talked about this listhesis as the cause of basilar invagination on several occasions. So there is listhesis of C1 over C2. There is now first issue that happens is weakness of the muscles and listhesis at the joint. Then all these other alterations happen like Chiari, Syrinx, basilar invagination, shortening of neck, assimilation of atlas, and all the things are all secondary. So first issue is listhesis. It begins with instability. And the treatment is instability is the issue and stabilization is the treatment. If you can get realignment, it is best. If you cannot realign, stabilize it strongly. So all the things that you are seeing here like Chiari, Syrinx, basilar invagination, atlantoaxial instability is due to the problem of muscles, and listhesis is the cause. So there is listhesis at C1, C2. This is the primary issue. Chiari, Syrinx, basilar invagination, assimilation of atlas. They are all secondary. Problem is C1, C2 instability. Problem is listhesis. C1, C2 stabilization is the treatment. It is not fixed dislocation. It is pathologically mobile dislocation, and the treatment is realignment and treatment is stabilization. This is another case where there is listhesis here. There is herniation of tonsils, syringomalia. These are all secondary issues. This herniation of odontoid upwards, that is not the primary problem. Problem is listhesis, stabilization is the treatment. Then more recently, as I have talked on several occasions about the concept of central or axial instability, atlantoaxial instability. There is no question in my mind that this concept will completely revolutionize craniovertebral junction surgery of the future, without any doubt. So this clinical entity, today I am talking of only type 1, but this central instability can be a cause of basilar invagination, Chiari, syrinx, cervical degeneration, spinal deformities, OPLL, Hirayama. This part I will discuss in my chapter 2. So what is central instability? And this recently we have written in Neurosurgical Focus, this article. And I wish and those who are interested will have to read this article, because we have summarized our entire experience in the year 2023 in Neurosurgical Focus about central or axial atlantoaxial instability. So central or axial atlantoaxial instability, we have divided into 3 groups. I am discussing only group A today. Group A means when there is central or axial instability and the issue is instability is primary, and musculoskeletal abnormalities, neural abnormalities that are primarily in the craniovertebral junction, those are group A CAD. Group B is when there is subaxial instability like degenerative spine, OPLL, Hirayama disease. And group C is, and believe me, this is quite a revolution in the field of craniovertebral junction. And the patients who have this, means in this there is CAD or central or axial instability without any other musculoskeletal or neural alteration. And patients who have this CAD, and if you treat this CAD after diagnosing it, you give brand new life to these patients. So this I will discuss. This is group C actually. So group A CAD, there is the primary issue. Now carefully see this slide, and I have mentioned only few entities. All these entities like bifid, C1, C2, 3 fusion, Klippel file, platybasia, Chiari, syrinx, external syringomalia, short head, short neck, basilar invagination. They are all secondary, they are all protective, and they are all reversible. Most important and most crucial thing that has to be understood is that if you see a patient with only Chiari, it is due to chronic atlantoaxial instability. If you see a patient with only C2-3 fusion, and believe me, my dear friends, this is such huge clinical implications. And I have got so many patients who have come with only C2-3 fusion, no compression, nothing. You treat C1, C2 fixation, and you have a magic. When a patient comes with short neck, and if he has no other problem, it is C1, C2 instability. If he comes with basilar invagination, no other problem, it is C1, C2 instability. So it has a huge implications in understanding and in treating. So this slide, many of you have seen several times, but still I will like to show. Atlantodental interval is the most or the only validated parameter to diagnose atlantoaxial instability. Facetal malalignment, C1 over C2. This kind of listhesis, so compression by the odontoid process, listhesis of C1 over C2, stabilization of C1, C2 is the answer. Type 2, you see there is no atlantodental interval disturbance, but there is a facetal malalignment. Facet of C1 is behind the facet of C2. And this is clearly an unstable situation. There is no need to do any foramen magnum decompression for such a situation. Believe me, if you do foramen magnum decompression, you have done nothing to the patient. You have probably harmed him. If you do any kind of transoral decompression or anything which is completely negative form of treatment in the presence of mobile, pathologically mobile atlantoaxial instability. So facet of C1 is behind retrolisthesis. Type 3 is when the facets are in alignment, there is no atlantodental interval disturbance, but presence of Chiari, presence of syrinx, presence of assimilation of atlas, presence of Klippel file, all other things are secondary, protective, reversible potentially to atlantoaxial instability. So I have no hesitation to say that this concept is here to stay. This concept will be understood eventually, but there is huge clinical ramifications of understanding this kind of instability. So there may be nothing with the odontoid process, but there is a retrolisthesis or type 2. The treatment is only stabilization. And this kind of basilar invagination with Chiari, with syrinx, no decompression. Problem is C1, C2 instability. Even when you do not see any facetal malalignment, you have to do C1, C2 fixation. Basilar invagination, no decompression is required, no problem with this, but you see the facetal malalignment. This operation, believe me, is not easy. It is dangerous. It is difficult. It will take your breath away during surgery, but if you can do it, that is the treatment. So if you see this, there is a problem in the craniovertebral junction, identify where is the problem, identify where are the facets, and you need to do C1, C2 fixation. Do not have to do any kind of decompression. Do not have to do any kind of occipital fixation. So when there is Chiari, it means it is secondary. When it is syrinx, it means it is secondary. When it is C1 assimilation, it is secondary. When it is bifid C1, C2, it is secondary. When Chiari is with syrinx, it is due to atlantoaxial dislocation. When Chiari is associated with basilar, it is C1, C2. If basilar is alone without any other problem, it is C1, C2. So C1, C2 is such a common entity, it has to be understood clearly. So there is no problem here, no problem here, but C1, C2 fixation is the treatment. So basilar invagination, instability is the cause and stabilization is the treatment. Few years ago, I had published my series of both group A and group B. The treatment is atlantoaxial stabilization. So basilar invagination is secondary to chronic atlantoaxial instability. Another word which I am now going to introduce before you is the word chronic, long-standing. So when there is a long-standing issue of instability, there are several reparative natural maneuvers which are in the form of Chiari, syrinx, and other things that I have mentioned. So chronic instability leads to basilar invagination. Instability remains and stabilization is the treatment. So Chiari, basilar invagination, syringomalia are all associated with atlantoaxial instability. And they are chronic form of atlantoaxial instability. And the nature does various reparative games. They are not pathologies. Like Chiari is not a pathology. Assimilation is not a pathology. Believe me, nobody has really understood this kind of correlation. But this concept is here to stay, and this will form a new revolution in the field of craniovertebral junction. Short neck, torticollis, this kind of deformity, even if there is no problem in the craniovertebral junction or in the spine, this indicates C1, C2 instability. You stabilize and there will be reversal. You stabilize and there will be a big smile. It will become long neck in the evening of operation. So you can give absolutely new life. And if you do not treat, this can lead to various subaxial problems, dorsal kyphoscoliosis, progressive weakness of the limbs and things like that. So torticollis and rotatory atlantoaxial instability is a very important when the patient comes with this kind of deformity, even if there is nothing here, you see nothing much here. And this is you do C1, C2 fixation and you create an absolute magic. Magic in the neck and magic in the function. And we have got several. There's no need for any osteotomy. There's no need for any form of decompression from lateral, from front, or from anywhere. The issue is unstable C1, C2. And you see after some years, the neck has become wonderfully long. And you see, you can see here, and you see how short neck and long neck, and you can see in the postoperative image, the person has completely changed. And you can bring beautiful smiles. And this is one patient which I had done. And he was on a wheelchair and now he's walking with his family. His neck has not become completely normal or aligned, but he do C1, C2 fixation and you can give him new life with his family and his child. So this kind of, they are indicators, they are completely clearly, whether you have any other corroborative radiological corroboration of C1, C2 instability is the question, and C1, 2 stabilization is the answer, and you can create magic with these children. So there are several patients where only C1, C2 fixation is necessary to give new life instantly to these patients. And initially I used to do intra-articular spacers to distract in a torticollis kind of patient, but now I do not do. You see this odontoid process is in a corner and now it is in the midline. I do not use much intra-articular implants at this point of time, which I described first in the year 2000. So atlantoaxial instability, and many of you have heard me talking. I will give a special lecture, separate lecture in my series on Chiari, but because my subject today is atlantoaxial instability, I will touch on few cases of Chiari and atlantoaxial instability. And we have published this series of, if you really ask me, my dear friends, absolutely no hesitation to say that a revolution in Chiari is made. No question. If you want to argue why this, no, I do decompression, I do this, and then it is completely, absolutely, in my estimation, nonsense. When I have produced so many patients and I have been able to give new life, I hope you can come to Mumbai, spend a few days with me, and I will show you a magic, a new magic of treatment of Chiari, and that magic is only C1, C2 fixation. So let me show you some cases rapidly. This is Chiari malformation. There is no problem in the facet, and I have done C1, C2 fixation. There is syringomalia, there is basilar invagination, there is assimilation of atlas a little bit. The facets are malaligned little bit. I have done C1, C2 fixation, not easy method of treatment, not easy. But if you can do it, you see the syrinx will disappear or reduce in the immediate postoperative period or in delayed postoperative period. But more important than anything is the clinical improvement like a magic. So syrinx is here, there is assimilation of atlas, basilar invagination, facets, C1, C2 fixation, this syringomalia has reduced. So Chiari is secondary, Chiari is protective, Chiari is a nature's airbag. Even when there is no atlantoaxial instability, no facetal malalignment, presence of Chiari is indicator of atlantoaxial instability, and stabilization is the treatment. No decompression. The syrinx can reduce immediate postoperative within second or third day. And in 100% of patients if you do imaging after 6 months. Most important is do a solid C1, C2 fixation. If you know how to do solid fixation, you can do wonders with these patients. There's no need to include the occipital bone. There's no need to do any kind of foramen magnum decompression. There's no need to do any kind of anterior surgery, and you have reduction in the serings. This is another case of basilar invagination and reduction in serings. Another beautiful case. You see the huge issue problem is do the fixation. This is another case where this is syringomalia, syrinx has reduced. So this is another case of a child having syringomalia, Chiari, basilar, difficult to do, but if you can do, magic is the clinical outcome. And absolutely, initially I used to do distraction and fixation. Now I do not do any distraction. I introduce some bone graft just for stabilization, not for realignment, and do C1, C2 fixation. And over the years, I have given new lives to several of these new patients, these patients with Chiari. As you know, Chiari is a relentlessly progressive problem. They start with hand problem, extend to leg problem, then neck problem, then breathing problem, then talking problem. And if you do in the evening of operation, they will say, doctor, I am cured. I have got a new life. So this is tonsillar herniation. The tonsil will go up, C1, C2 fixation is the treatment. And as you are seeing, you see there is facetal malalignment. I have done fixation, no decompression. This is another case of, this I have shown you already. This is syringomalia, tonsil. Tonsil has gone up, syringomalia has reduced, only fixation, no facetal malalignment. This is another case of syringomalia. No problem, some bifid here, and the syrinx has reduced. This is another beautiful case for your visual delight. You see there is a facetal malalignment, no decompression, syrinx reduced. This is another beautiful case, no problem, and the syrinx has reduced. Basilar invagination, of course, when it is present, they are all, basilar invagination will be present with Chiari several times. Syrinx will be present with Chiari several times. Assimilation of atlas will be present several times. They are all children of one father, and that father is atlantoaxial instability. So there were many conflict of opinions and discussions and all those things against this concept, but there is no question that this concept is here to stay. Even when there are no bone abnormalities in the craniovertebral junction, atlantoaxial instability is the cause. You see, there is nothing much, no basilar invagination, no assimilation of atlas, but there is a facetal malalignment, no decompression, fixation. This is another case of Chiari, do fixation and syrinx will reduce. Syrinx will reduce in 100% of patients. And that is my challenge, and that is my absolute conviction regarding this treatment. You see, this is pre-op and this is post-op. There is this problem here. The syrinx is big, syrinx is reduced. It is whether the syrinx reduces or not reduced. That is not the primary issue. The primary issue is that the patient will remarkably recover in the clinical symptom. That is about Chiari. As I have told you, I will discuss Chiari in a separate lecture because it is a huge subject. So short neck is a manifestation of atlantoaxial instability. Short head, you see these patients have short head. So Chiari is a manifestation of short head. Short body height and short spine, they are all associated. So Chiari and atlantoaxial instability can have huge secondary reparative natural mechanisms which changes the whole body. They are all secondary and they are all protective. Idiopathic syrinx, if it is present, nobody knows what to do, but you have to do C1, C2 fixation. And this is syrinx is one of the children of C1, C2 instability. External syrinx, we had introduced this beautiful new term called external syringomalia. You see, there is more water in front of the cord. more water in front of the brainstem. So this I called external syringomyelia. This I call external syringobulbia in the presence of tonsillar herniation. So these are also like internal syringomyelia. When there is external syringomyelia alone, it indicates presence of atlantoaxial instability. If there is no other problem but external syringomyelia, you have to do C1, C2 fixation. So there can be, see, there is more water in front of the cord. This is external syringomyelia. There is internal syringomyelia. There is external syringomyelia. There is external syringobulbia, internal syringobulbia. Internal syrinx, external syrinx. Internal syrinx, external syrinx. So external syringomyelia is like internal syringomyelia. You see so much water by the side of the cord indicates the presence of C1, C2 instability. External syringomyelia can also be present in benign tumors. Like you see, there is a tumor here and there is a lot of CSF here, lot of CSF here. So external syringobulbia and external syringomyelia is a protective natural maneuver in the presence of a chronic situation affecting the craniovertebral junction cord. So Chiari malformation can be present in pediatric age group or adult age group, no question when it is present, but C1, C2 instability is the issue. Syringomyelia is secondary. It is protective. It is reversible. And you see this is unstable. There is syringomyelia. I showed you this slide. You have to do C1, C2 fixation. If you tamper with the syrinx, you can harm the person very badly. Another very important thing is cervical fusions like assimilation of atlas, C2-3 fusion, Klippel file abnormalities. They are all secondary, they are all protective, they are all reversible. And they are all indicators of C1, C2 instability. You see, there is external syringomyelia here. And there is multiple levels. So if you do any kind of decompression, you can harm the person. So this is central instability. And atlantoaxial fixation is the treatment, and MAGIC is the clinical outcome. So when you see only bifid, when you see multiple levels of cervical fusion, even and there is external syrinx extensive, these are indicators of C1, C2. Any other form of treatment, it will be an absolute negative form of treatment. So C1, C2 fixation has a huge implication if you have a patient like this in the life of the patient. I have said in my article that os odontoideum is a self-destruction, like syringomyelia is a self-neural destruction in the presence of chronic instability. So this break in the odontoid is a natural mechanism of chronic instability. When you see os odontoideum, you don't have to see anywhere. It is C1, C2 instability. You have to do C1, C2 stabilization. And you'll be surprised to know that many people still do transoral decompression and several people still do occipital fixation for this entity. This is just C1, C2 instability, and you have to do C1, C2 stabilization. So os odontoideum, even when you see only little compression, there is no decompression required. What you have to do is, you see external syringomyelia here, external syringobulbia. This needs C1, C2 fixation. And we have got, as I have shown, several hundred patients. Now, if a patient comes with C2-3 fusion, you see this patient has C2-3 fusion. Now there are compressions downstairs here at C3-4, C4-5. This patient I have done in this patient, this was my first case, so I did fixation here also, subaxial. But it is not necessary. What is necessary is only C1, C2 fixation. These are all secondary. These are all protective and they are reversible. Primary is C1, C2 instability. You treat primary, there is no need to do subaxial fixation. So this beautiful article of mine is C2-3 fusion and evidence of atlantoaxial instability. If a patient comes with only C2-3 fusion, it is a clear evidence of atlantoaxial instability. You see there is C2-3 fusion and there is C3-4, and I have done only C1, C2 fixation, and MAGIC is the clinical outcome. Do not go for this secondary affection which are reversible. Like short neck creates torticollis. Short spine creates kyphoscoliosis. So can you believe that kyphoscoliosis can be due to atlantoaxial instability? So if there is a kyphoscoliosis and Chiari and syrinx, of course, you have to treat C1, C2. But even when there is no C1, C2 instability seen on imaging, it can be due to central instability, and you can avoid, you see this kind of curvatures, they can go within 1 month. And most importantly, this patient will remarkably recover very quickly in his neurological symptoms. So these kind of kyphoscoliosis, of course, when there is syrinx and Chiari, you have to do C1, C2. But even when they are not, you have to identify central instability. And in this age group, many of these patients have central atlantoaxial instability. And many of these patients recover in their motor evoked potentials during the operation. Another very important anomaly, quite a rare anomaly, is omovertebral bone and clipal file. Omovertebral bone means, like you see, there is a hump in the neck here, and this bone is quite a large bone here. This bone is attached from the vertebral body to the scapula. You see, to the scapula. I have called it cycle stand. This is a cycle stand. This bone is indicator of atlantoaxial instability. This cycle stand is it protects, it gives support to the neck. And this is a beautiful, when you see this cycle stand, it is C1, C2 instability. Don't start removing this cycle stand. You will harm the interest. You do C1, C2 fixation, and you will create a magic. You see, this is another cycle stand here. The problem is not with this. This is natural protection. Do C1, C2 fixation. So central atlantoaxial instability, I will discuss as a separate lecture later, as to you can have atlantoaxial instability without any, and I have got a very big series now of central instability without any other anomalies. And of course, when there is syrinx, even when there is no compression, you have to do C1, C2 fixation. When there is bifid, even if there is no problem, you have to do C1, C2 fixation. You see, there is external syringomyelia here. This patient was an international patient that I treated during COVID times. And you see here, there is extra fluid. And this deformity is due secondary. It is protective and it is reversible. This patient, I had done multi-segmental fixation, but I realized that this patient, I could have done only C1, C2 fixation, and I could have created the magic. And this patient instantly, during the postoperative period, you see the hand was not going up. The hand is going up now beautifully. The shoulder was drooping. The shoulder has come back to normal. Another last entity which I will rapidly discuss with you is the absence of posterior elements of C2. We have discussed about bifid C1, but posterior elements of C2 can be absent. And this posterior element of C2, even if there is a big deformity here, the problem is not here. In my initial experience, I did decompression and multi-segmental fixation. I also did for this kind of C2-3 spondyloptosis, I did decompression first and then this transoral fixation. I did this early in my experience, but now I realize that in the cases of absent posterior elements of C2, like in this case, the absent posterior, this is C1, posterior elements of C2 are lost. This is C3, and you can see beautifully here posterior elements of C2 are lost. And when there is this kind of situation, what you require is C1, C2 fixation. Central instability is the issue. This is another case of C2 posterior elements lost. Do C1, C2. Do not bother about what is happening in the subaxial spine. Do not start decompressing the cord at this point of level. And I've got several cases like this. Similarly, cranioatlantoaxial instability can be associated with tumors and with neurofibromatosis. I will discuss in my next phase of my discussion. And this is another case of absent C2. And this is atlantoaxial and subaxial instability can be present in neurofibromatosis. And this is instability, quite a devastating clinical entity. But if you understand C1, C2 fixation, and if you understand subaxial, you can absolutely and certainly give new life to these unfortunate patients. And there are many of these patients. So this I will discuss in my next chapter. So thank you very much, my dear friends. I hope I have taken you around the journey of craniovertebral junction instability, part 1. Part 2 and part 3, we will discuss about how atlantoaxial instability can affect the subaxial spine. That is part 2. How atlantoaxial instability can be a discrete clinical entity. That will be part 3. So thank you very much, my dear friends.
Thank you, Atul. That was a great lecture, and it looks like the panel is going to be very dynamic. I see a lot of questions up there, and we'll let Harshad Parekh, the neurosurgeon from Mumbai, lead the discussion. Good day, Harshad.
Hi. Yes, Professor Atul. Wonderful. Superb. As always, you are always teaching us something new. Today also we learned something new. Although I've heard you 100 times or more than 100 times, but still I feel every time it is new. And I agree, you have revolutionized the management of C1, C2. When we were residents in 1985, 84, and we used to think, oh, C1, C2 has come and patient will never improve, and all these things were there. But now it seems to be very, very easy by your way of putting up this C1, C2 fixation. And today you touch another thing is bifid C1 spine and rotatory dislocation, which also can be corrected. And third thing, as Dr. Rahman was also asking about Klippel file, you are saying C2, C3 fusion and C1, C2 fixation can help. And Dr. Rahman is also asking about the vertebral artery injuries. What do you have to say?
So vertebral artery injuries can be there. There can be neural injuries. So you have to avoid them, because if you have such injuries, you create devastation. If you create a deficit in a craniovertebral junction surgery, you have created a disaster. On the other hand, if you have treated it properly, you give new life to the person. So it is either here or there. So if you create a neurological deficit, I'm not saying I have never seen vertebral artery injury. I'm not saying I have never had any. So that is another thing, how to protect vertebral artery during surgery, how to protect the neural structures during surgery. But basically, if you read my articles, the complication rate over the years has become absolutely close to zero. I'm not saying zero, but close to zero. But they can happen. And so you have to learn this. That is the thing, because I'm saying that atlantoaxial instability is so common and so frequent and so neglected. I think one has to learn it properly and learn it nicely. The vertebral artery, of course, has to be taken care of. Vertebral artery has to be handled beautifully and with care. And then you have to identify how to fix it, and you have to fix it solidly. If you do a flimsy operation and if your fixation is not solid, your outcome may not be solid. So that is the thing, Harshad.
There is another question. What is the mechanism of syringomyelia in these cases? This is in chat box.
Yeah. Syringomyelia, you see what we have discussed on several occasions, and even in my first lecture, I said that water is life and life is water. Water is the basis of everything in the life. Like if you stand on water, you move on water, and water can never go wrong. Syringomyelia is secondary to chronic atlantoaxial instability. Syringomyelia is a protective. Water formation is protection. It gives buffer. It gives protection to the cord. Water is the most incompressible structure of the whole planet. There is no other structure in the planet which is more incompressible than water. So how it happens, the nature produces this water inside the cord, outside the cord. I have introduced this new term, external syringomyelia, which is also such a fantastic clinical entity. And I can tell you that many patients of craniovertebral C1, C2 instability I have diagnosed with only one parameter, and that is external syringomyelia. So it is not an ordinary clinical entity. We have to know this entity, and now we have to, learn it properly and understand that there are various manifestations of this father atlantoaxial instability. There can be manifestation with neural anomalies, musculoskeletal abnormalities, bony abnormalities, and so many abnormalities. So that is syringomyelia is, and I have written a beautiful article on this subject as to how the syrinx is formed probably and what is the role of syringomyelia. I will like you to read my article on this subject. And also I have to tell you that whatever I am saying, whatever sentences I am saying are all published. So I will like you to read my articles if you want to know more about what I am saying.
Wonderful, wonderful. Thanks, Atul.
Hello, Dr. Atul.
Yes,
I gave a talk about some spinal problems where stability has to be respected as well, when you do all sorts of microsurgical procedures. But anyhow, I had the task of in '94. I came across an atlantoaxial rotatory rotation. Actually was neglected, and back then in the place I was working, there weren't very many implants, and so what I did is I exposed the C1, C2 joint. There's the nerve root there, but I managed to displace it. Some people are advocating to even cut it. That was not necessary. With a bit of diamond drilling inferiorly, I could displace it. And then I put a screw, and there were no proper screws, so I put a malleolar screw from C2 into C1. So I did that on both sides, and the patient actually did remarkably well. Now I see I'm sure you have a lot of technical details to talk to us, how to get the access to C1, C2 regarding the nerve root, especially in these deformed cases. And also I see you're using two screws now, lateral mass screw and C2 screw, and then you connect them. And then what do we have to remember when we connect them? Can you please elaborate a little bit technically here?
This C1, C2 fixation is a very difficult operation. It has to be learned on cadavers. It has to be seen, and it has to be performed. And it has, there are several articles, my dear friend Martin,
I know,
where I have written on how to do C1, C2 fixation, when to cut the C2 root, when not to cut the C2 root, how to handle the high riding vertebral artery, how to avoid, how to manipulate, how to dissect in that area, how to control the venous bleeding in that area. There are so many issues that I have discussed.
A lot of aspects,
yes. Many aspects. This is not a small operation. This is a big operation. And you are in this business for a long time. But if we have to do it, we have to do it properly. And we can certainly give brand new, wonderful new life to our patients. And fortunately for me, I've been doing this for approximately 36, 37 years. I'm doing this C1, C2 fixation with this technique. And my experience now goes beyond 3,700 cases of this fixation. So I'm very happily trotting along. Let us see how I go further.
Okay. Right. So, but would you mind that at some stage, you're presenting so many beautiful cases to inform us a little bit, and I will certainly get into all of your articles regarding the technical details. This is also important to spread the news to people that this can actually be done. We have learned how to work with the microscope. We have learned how to work with aneurysms, with all sorts of things. So we can learn that too, but we need maybe a little bit of a motivational talk by you, giving some technique. And I'm sure you have plenty of experience of what to do and what not to do, kind of pitfalls and tricks.
So now I have many people on the screen, and I will first like Yang Dong. Are you there, Yang Dong? Yes.
Yes, I'm here. Thank you for your beautiful lecture. I think like John, I have listened so many your lecture on the topic of cranial of parental axial instability, and I have read so many your papers, and I really like your concepts. Still, my do foramen macular decompression for clearly see facilitate more alignment in so many of these cases. So I think if there are some neurosurgical centers, every people should visit in their lives, then maybe the King Edward Memorial Hospital, Tata Memorial Hospital, Virabhadri Hospital, and the Somaya Hospital are four of them. Again, thank you. Every time I learn so much from your lecture. Thank you.
Thank you. Thank you. Thank you, Yang Dong. I've also, Dr. Salek is here. Salek?
Oh, sir. Thank you,
Yes.
sir. Actually, I was waiting till your
Salek, your voice is
finish.
cracking.
First of all, I'm thankful to. Yeah, can you hear me, sir?
Yes, better.
Hello.
Yes, we can hear you.
Yes. So I'm thankful to you that I have the scope to visit your center to see the cases, to learn the technique, because you know C1, C2 instability and subaxial multilevel spondylolytic myelopathy. Those are nightmare for me. Once I have learned this technique and I started doing these cases with C1, C2 stabilization, so I am now relaxed because I can find that the evening after the surgery, the patient is happily, smiley, and it's a magic. And credit goes to you, sir. Thank you, sir.
Thank you, Dr. Salek. And here, Mohammed. Mohammed.
I think we're caught up. Does anybody have any parting questions or anything they'd like to share? Okay, Mohammed, go ahead.
Yes, hello. How are you?
Good.
It's good to hear
Yes,
you
Mohammed.
and follow you. I'm sorry, I'm a little bit on the street, but I'm not
Okay.
missing
That's okay.
new indications. Do you hear me?
Yes, Mohammed.
Yeah. Thank you so much for the new ideas. I like the omovertebral bone.
Cycle stand.
It's a new for me. You all always with a new thing, you know. Congratulations. Thank you so much.
Thank
My
you.
internet is not very good, but I heard every word you said. And I think we should call you all the spine of a neurosurgeon. You're like our spine. We are learning and rising up because of you. Thank you so much.
Thank you, Mohammed. Yeah, John.
Yes, okay, very good.
Takashi is there.
Oh, Takashi, you want to say hello? We haven't seen you for a while.
Takashi was on holiday. He
Oh,
came
so
back.
Okay. I guess he must have stepped away. Okay, very good, Atul. Okay, so next week you already said it's part 3, correct?
Not next week, a week after that.
2 weeks. Two
I
weeks.
will give you further instructions soon, okay?
Okay, very good. Thanks everybody for coming.
Thank you.
We'll
Bye-bye.
Thank you.
See
Thank
see
you
you in
once
2
again.
weeks.